Hello, everyone. This is Dr. Alex Vasquez with John Bartemus, and we're going to go through this quick case. Sorry about the clicking noise there. John, can you present this case, and then we'll just kind of walk through it and talk about what we might do in a situation like this?
Sure, yeah. Thank you, Alex. This case, he's a 63-year-old white male, 220 pounds. He's got a history of deep vein thrombosis a couple times. No other, well, and a long history of high cholesterol. His dad passed away of Parkinson's at 91. His mom passed away of dementia at 89. Neither of them had a history of heart attack. He currently works out 5 days a week and has for a few years. He eats better than the typical American, which basically means he's more aware of how he should eat because of, how I've educated him. It's better choices than he does, but if left to his own devices, he'd probably regress to the typical American. He doesn't currently take any supplements and hasn't for a while. And it's one of those things where unless I give him the supplements, it's not a thought in his mind and he doesn't take anything. And so last week he called me because he had been having chest pain for 3 days. And he explained it as it's worse when he wakes up and when he goes to bed. It's better after his workout and while he's working during the day. He's a contractor, so he's doing manual labor. And so that made me think, hey, it's probably costochondritis or some sort of somatic driver of the chest pain. I had him come into the office. I found upon examination a rib head out posteriorly, and if I palpated the intercostal muscles around the heart, that caused pain. So I said, hey, this is at least a big somatic driver, but let's run some labs anyways based on your history, and let's send you for a coronary calcium score because of what a great test that is for 10-year risk of heart attack. Mm-hmm. So I adjusted the ribs that I found that day. I did some muscle work to the intercostal muscles, and then we sent him immediately for the lab test. He had eaten a sandwich within the hour, so throw out the lab high glucose that you'll see. And he did the calcium score the next morning.
Okay. So let's take a look at those results, assuming that my computer will advance. There we go. So here's what you picked up on those labs and the imaging.
Yeah, so this is the left anterior descending artery, aka the widowmaker. Mm-hmm. And you can see the area that's circled is very, very white. And so this is a CT calcium scoring test. Basically, it's looking for coronary artery calcium. And the more coronary artery calcium, essentially the larger the plaque or the more atherosclerosis in the area. You'll see on the left-hand side, the score should be 0, and the LAD score is 398.
Right.
So that's a discussion that we want to have because, that's known as the widowmaker for a reason.
Sure. So let's just talk about the data that we have right now. So, 63-year-old man with obvious cardiovascular disease that we're looking at right now. I mean, this isn't like a surrogate lab. This is exactly imaging the fact that he has atherosclerosis. So this isn't like looking at lipids where it's kind of a surrogate marker associated. This is telling you he has atherosclerosis. So there's no question about this. You also mentioned that he had a history of DVT. Can you tell me more about that?
Yeah, so he's had, specifically in the left calf, he's had a couple DVTs, and he has venous insufficiency in that leg, and he's had surgery on the veins.
Right.
I think 2 times.
Okay. So let's just stop there, if you don't mind. What initiated the DVTs? Like, were these spontaneous DVTs or associated with like being bedridden for a long period of time?
No, they were spontaneous.
Okay, so that's obviously not normal. So he has something going on. And sorry, what was the age of his first DVT, if you know?
Those were a good decade ago.
Yeah, so middle age.
Yeah.
So I think that in like medical school, for example, this is exactly where we get pimped on like risk factors for DVT. So risk factors for DVT: obesity, inflammatory disease, being bedridden, things like that. None of that appears to apply to him. So then we have to look for other possibilities, like especially genetic disorders and things like that. So uh, for medical board exams and for getting pimped on rounds and things like that, I memorized like the four main risk factors, and you may know them too. I'm not saying that you don't, but I'll tell you the way that I memorized it. It's a stupid little rhyme, but it worked well enough for my exams and other purposes. So the way that I remember this is 5 homo. I'm writing it down as I say it. 5 homo pro cardio, and those are the risk factors for spontaneous DVT. Uh, the 5 stands for factor 5 Leiden. It's a genetic mutation that causes people to be hypercoagulable. The homo stands for homocysteine. The pro stands for prothrombin mutation, and cardio stands for anticardiolipin antibodies. So he may have one or more of those risk factors, and that would be like some good labs to run on him. Again, it's factor 5 Leiden, homocysteine, prothrombin mutation, and anticardiolipin antibodies. So people shouldn't develop spontaneous DVTs, So if they develop spontaneous DVTs, it's because they've got something going on. That would only make him at higher risk for occlusion. And he's already got the structure for occlusion, and he's got the biochemistry for occlusion. So he's a heart attack waiting to happen, basically.
Correct.
So
and historically, just per your rhyme there, historically his homocysteine has been between lab high and functionally high. Every time we've tested it, he's decreased it with lifestyle changes and functional work, but that he's never, it's like once he sees it changed on the lab, it's back to life, right?
Yeah. Well, that's
so my hope is that he sees these undeniable images and labs and anchors it to something that will carry the habitual change longer than a month.
So based on only the data that we've talked about right now, which is past history and looking at this calcium score, like if this patient were in my office, I'd send him out like right now. Send him out meaning like this week you will consult with a cardiologist and I'll make the appointment for you and here's the directions or here's the address, right? But the way to manage this from a clinical standpoint would be especially if you're practicing as a DC, would be to send him to either a really, depends on the social context, but it could be family medicine, it could be internal medicine, or if you have a cardiologist, then send him to a cardiologist. But this patient's ultra high risk, right? So that's just the way that it ought to be managed, and that would be true, if you're a DC practicing with a patient like this, that's how I'd manage it. If I were family medicine, what would I do? If I were practicing like as a family medicine doc or naturopath, like in a state where there's licensure and drugs and all this stuff, I'd still send him out. Like this is not a patient that you want to have where you're the last one who's seen him. This is ultra high risk, and just based on what we're looking at now, he's got some type of mutation going on that's making him hypercoagulable. He's got this calcium score, and you don't know when the next shoe's going to fall. So that's how I'd manage it. It doesn't mean giving up. Like You can still do whatever you want. I would still treat this patient, but he's got to be referred up, basically. So that's where I would take it from here. If you're ready, we'll go to the next page.
Sure.
These are the labs that you sent. I just put them in kind of raw. So if you don't mind, I know this is your case, but I'll let you take a breather and I'll go through the labs.
Sure. Just remember, we can throw out that glucose.
Yeah, right. It's not that high anyway. For a postprandial glucose, it's not that bad. So interestingly enough, his hemoglobin A1C is actually normal. Uh, One thing that I didn't see on here that I'd like to see is fasting insulin. So I'll put that on my list of actions.
Yeah. I actually ordered a C-peptide, but they didn't run it,
Okay.
unfortunately.
Uric acid's all right. BU and creatinine. The other thing that I noticed that they didn't. Oh, I'm sorry, they did give it. GFR for non-African American 65. So he's on the lower end, but still normal. I don't know if that is or isn't actionable at this point. But I have seen people, at the lower end of GFR, and they end up with almost fatal hyperkalemia. So once it starts getting low, even though it's still normal, I think it's a cause of concern. These other things look all right. Magnesium. He's at the upper level of magnesium. That's interesting. Actually surprising. LDH. LDH is definitely at the high end. So let's go on to the next page. I didn't pick up a lot on that one. Ferritin's definitely too high. So for a white male, his ferritin, we'd like to see that more like 40 or 70. So certainly not 268. That's way too high. So that's another risk factor for cardiovascular disease. Total cholesterol at 324 is outrageous. Triglycerides are okay. We'd like to see those below 100. HDL is nice. VLDL, moderate, but low, good. LDL too high. Some people either do or don't pay attention to that these days, but I think the bulk of the research suggests that should be below 100. So anyway, he's got risk. Cholesterol is too high. Some people these days are trying to ignore that, but I don't think it should be ignored. C-reactive protein's outrageous at 29. Wow. And like you said before, his homocystine's too high as well. So that's big trouble. So he's still, he's hypercoagulable. Did you? I think you did. There's a fibrinogen on this test.
Yes, next page.
Okay, thanks. Mm-hmm. That's the one we just looked at. Homocystine's too high. It should be 5, 6, 7, not 14. TSH is a little bit high at 3. Reverse T3 is at the top of the range, so he's at 23. Top of the range is 24. So anything you want to say about either of those pages?
Sorry?
Is there anything more that you want to say about these pages that we just looked at?
No, I think you nailed it.
Yeah, so let me just make a few notes. So I'd like to see a fasting insulin. His cholesterol's too high. His CRP is too high. His homocystine's too high. He could probably use some thyroid support, in my opinion.
Yeah.
With T3 specifically, that would lower his TSH. It would also lower that reverse T3 elevation. But, doing that in a patient with cardiovascular disease is questionable as well. So some people would say, well, you should give him a little bit of thyroid just to help him lower his cholesterol level, improve this and that. Other people would say, well, if you give him thyroid, you're going to increase cardiac demand. That's going to put more stress on his heart and increase the probability of a problem. So probably nobody would touch that at this time. Vitamin D level is good. His fibrinogen's way too high. So, I consider fibrinogen to be high at 200, and he's over 500. So he's very hypercoagulable right now. Very hypercoagulable. CBC is all right. Mean cell volume is too high at 95, so he might be deficient in folic acid B12. I'm not picking up a lot more on that page. His urine pH, I noticed at 5.5. So he's metabolically acidic. He'd probably be better off more alkaline. Nothing else. D-dimer noted to be high. I think, especially if you look at it age-adjusted cutoff and all that kind of stuff, it's still too high. Lipoprotein A is too high as well, so it's another risk factor. Do you want to comment on these?
Yeah, I was just going to say my family, from a family history standpoint, whenever we tested, all of our cholesterols would be, statin worthy in a conventional medical setting.
Mm-hmm.
And this is the first LPA that I've seen on any of us, so I'm interested to go back and run one on myself and
Right.
have other family members do it, because the LPA is an indicator of, is there a genetic contribution to the high cholesterol?
Mm-hmm.
And so even if there is, obviously want to optimize our levels, whatever that means, with the genetic contribution to it. Like
Mm-hmm.
he has a 324, so does that mean we just brush it off and say, oh, it's genetic? No, because we know there's issues in his lifestyle that we could optimize that may help bring that down to a more palatable number. So that was an interesting finding for me.
Yeah, no, I agree.
I think from the D-dimer side of things, how much does that alert you, given everything we've covered so far?
Well, my overall interpretation is clinically significant hypercoagulability.
Okay.
So that's why I'm not a cardiologist and you're not a cardiologist. That's why we send out to cardiologists, Whether they want to start either a traditional anticoagulant or one of the newer anticoagulants, that's their call. But I suspect that someone might want to do that. But, those people look at those guidelines all the time and they can make that call. But this patient concerns me. Early in my practice, I had a patient with he had inflammatory autoimmune disease, and he had risk factors, and he had a specific physical defect in his heart, and he was ultra high risk for cardiovascular disease, and he had a heart attack, and while he was my patient, and of course that really threw me. So, and later in medical school, I saw some patients who were dying of heart attacks, etc. So basically what I learned from those experiences is to take these cases really, really, really seriously, because heart attacks happen, and sometimes they don't announce themselves.
Right.
Maybe like in this case, the patient reports some chest pain, which may have been coincidental or may have been angina, but you never know when this patient's going to have a heart attack. It could be later today, it could be next month, it could be this year, but this patient's ultra high risk, and he has to appreciate. That's why it's called the Widowmaker, as you said earlier today. It didn't get that nickname, for the fun of it. It's because it kills people, especially men, and this patient's the classic example of that. So
I think another thing this patient is a classic example of is that because he feels fine, he thinks he's healthy.
Right.
And I'd like to talk to the other clinicians out there that, I could have easily, after examining them, say, oh yeah, you have a rib out, which would explain, chest pain and difficulty breathing. So we've adjusted it. Follow up Monday. If you feel fine, you're probably good, right. And not have run labs, not have done the diagnostic testing, and then, not have served this patient correctly, and maybe expose yourself to liability.
Sure. Absolutely. So, like I said before, like this patient could die today, tomorrow, next week, next month, but the heart attack is coming, unless we collectively uh, do something about it. I
Mm-hmm.
just very quickly, I'll tell you another case that I had that also kind of put some fear in me. Uh, it was a Friday afternoon. New patient comes in, brought in by her daughter, obese African American woman, and she had hypertension. And I don't really think I picked up on anything else other than just like I felt concerned for her, like disproportionate to clinical findings. It's like something's not right here. So uh, I said, I said, I said the thing I really need to do in this situation is I need to send you to the emergency room. And she wasn't having chest pain. We didn't do an EKG in the office, even though we could have. And I had already started to write books and articles on hypertension at that time. So I felt confident that I could manage her case, but something just didn't seem right about it. So I said, I know this is going to be inconvenient for you. It's Friday afternoon, and I need you to go to the hospital right now. So I sent her to the hospital, and I didn't know what happened. And then I called her a week later, the following Friday, and I said, hi, Dr. Vasquez, I'm just calling to check in on you and see how you're doing. She said, baby, I just got home from the hospital. She had been in the hospital for the entire week because when they did an echo on her to evaluate her cardiac function, they found out she had a cardiac thrombus that
Oh, wow.
could have easily killed her like that weekend, right? Well, if I had done my usual nutrition stuff with or without drugs, and she died that weekend, it would have been my case, you know.
Mm-hmm.
So that's another example where, like, I don't know. At some point I developed what I called like the weekend rule, and the weekend rule is if I'm going to worry about this patient over the weekend, they need to go somewhere else, you know.
Yeah.
So if it's not a situation where you're very confident that you're in control of the case, and I'm just using that language kind of because it's easy, but control or comfortable, whatever. If you're not really comfortable with it, send it out. You know, the worst that's going to happen is it's inconvenient for them, and some other doctor will write you back and say, look, you could have managed this without, consulting me. I guarantee you that no one is going to tell you that in this case, right? If you
Right.
send this patient to an internal medicine doctor or cardiology or even family medicine, they're not going to write you back and say this was a waste of my time. That's for damn sure, you know.
Mm-hmm.
So I just think this is a case that needs almost urgent attention. It's not like urgent care, like this patient needs treatment immediately kind of thing, but like this patient needs to be in someone else's office this week.
Yeah.
So I'll run through. Do you want to do what you would do for action plan, or do you want me to run through mine real quick?
Yeah, you can go ahead.
So this is stuff I just wrote like as we're talking. I didn't plan ahead. I just took a few notes. So like I said before, 5 homo pro cardio. You could still test him for factor V Leiden. You already know his homocysteine is too high. You could test him for prothrombin mutation if you want, and you could also test him for anticardiolipin antibodies, probably normal in his case. But again, you don't know until you test him, because a couple of DVTs in a guy makes no sense at all. So something's going on. And to be honest with you, I don't really think that the homocysteine explains the DVTs.
Okay.
Possibly the homocysteine and the inflammation might explain the DVTs, but I would still run those other tests. I'd get a fasting insulin. Whoever he sees from the medical or osteopathic world is going to put him on statins. I think that's just what they're going to do, and that may be acceptable in the short term. The data is, in my opinion, very unclear on that. But it would still be considered standard of care.
Okay. So he has, in the studies on calcium scoring, they say if the score is over 100, that's routine. It's basically statin and aspirin therapy.
Right.
And he has history of Lipitor, which caused weakness and muscle pain.
Sure.
That was in the mid 90s, and there was no CoQ10 on board or any of that. So
Right.
We'll be sure to include the CoQ10 if he goes,
For sure.
if they put him back on it this time.
300 milligrams for him. And statin-induced muscle pain correlates more strongly with vitamin D deficiency, which in this case he doesn't have. But I think the statin that we used to use in our office was Zocor. We didn't use Lipitor. We just found that Zocor was better tolerated. So you could try him on a different medication. But someone's going to want to do something about his elevated cholesterol, and arguably appropriately so. For the CRP, his magnesium level was already normal. You just mentioned aspirin. I'm sure somebody would put him on aspirin. And fish oil. So, probably for him, 3 grams a day of EPA and DHA. That's a little bit more than the norm, but he's also at high risk. So I would definitely go fish oil.
So even with whatever pharmaceutical anticoagulation.
Right. So he doesn't have anything on board right now. So we'd have to make that adjustment, at the time. But you could run a omega-3 index on him and see what it is. I suspect, unless he's eating fish, twice a week, then I suspect his omega-3 index is probably like a 4, and we'd like to see it more like 10.
Yeah.
So I suspect that he still needs a correction there. For the homocysteine, you've got B6, B12, folic acid, and NAC. Those are the big players for lowering homocysteine. So that's what I would do. You could try to optimize his thyroid, but I don't think anyone's going to touch that until he gets out of the fire that he's almost in. So yeah. Mm-hmm. If he were in perfect health, complaining of a little bit of fatigue or depression, we could try to improve his thyroid status. That's just kind of gilding the lily at this point. It's not a priority as I see it. And anybody who prescribes thyroid for him in this condition is asking for liability in any malpractice case. So I wouldn't go there. So let's back up again. So he's got cardiovascular disease. There's no question. You're looking at it. And he's hypercoagulable. So what are we doing for the hypercoagulability? Making sure his magnesium status is good. Aspirin, fish oil. I would put him on those things like right now until he gets into somebody else's office, which should be like Monday or Tuesday.
Got it.
Yeah, I mean, this is way worse than some other cases I've seen where people actually had heart attacks. So this is just too risky. So, referral means phone call, making the appointment, and communicating all that to the patient and charting it. But that's where I go with this. Like, there's no question.
Got it. That's what we'll do.
Yeah.
Thank you for your expertise.
Yeah, well, thanks for the case. It's a good case.
Well, and it's great to have someone with, that comes from the functional paradigm, but has the history in the hospitals and in the medical world to be able to differentiate between, hey, this is someone to send out, or this is someone that you make a few lifestyle changes and you're good to go.
Yeah, exactly. No, and I appreciate what you just said, so thank you. But I also, I paid pretty heavily for that experience, and what I mean there is when I started practicing and then relocated and all this stuff. But anyway, I was probably about 3 years into practice after graduating from DC and then ND school. And I wasn't ready to take on cases like this. Even though I was seeing some cases like this, I can see now that I wasn't ready, Mm-hmm. And that was part of the reason why I went back to medical school, was just to learn a little more. And whether it did or didn't help, I presume it helped. But the fact is, with or without that additional schooling, I think the conversation that I needed to have had earlier was the importance of taking these cases really seriously. Like cardiovascular risk at this level isn't something that you mess around with,
Yeah.
There's some things, like you had said just a moment ago, in the functional medicine world, there are lots of things we can handle quite well. But this, And this may be one of them. In fact, it is one of them, but he's in an urgent window right now where he needs to be stabilized, right? Uh, it's not like he's on the floor, having difficulty breathing. I don't mean stabilization in that sense, but what I mean is this is very precarious right now. And whether he's symptomatic or not, you as the professional have to make the call and say, I'm glad you feel fine, but you need to take this seriously, and this is urgent.
Yep.
So
I will do it.
Yeah, that's where I'd go with it. All right, so we can call it a wrap.
Yeah.
I
That was
will
awesome. Thank you.